So we're going to talk about laser and the treatment of Morton's neuroma. So first of all, a quick recap of what Morton's neuroma actually is. So Morton's neuroma is a bit of a misnomer. It isn't a true neuroma, but more a reaction of the nerve and the tissues to trauma. So it would be more appropriately referred to as a perineural fibrosis. The condition occurs when the nerve sheath between the third and fourth metatarsals becomes inflamed. That's often as a result of trauma or overloading the forefoot. The inflammatory process can lead to the formation of scar tissue. Morton's neuroma is most often seen in middle-aged women, which I suppose is most often down to footwear, high heels or compressive toe boxes cause that compression between the metatarsals. There are other intermetatarsal fibromas available between fourth and fifth metatarsals, Isolin's neuroma, Hauser between the second and third, Hutter between first and second, and Joplin's neuroma can affect the medial element or aspect of the first toe. But Morton's neuroma is far and away the most commonly seen one, so that's what I'm going to talk about tonight. So commonly described symptoms are burning, aching, numbness, and tingling. These symptoms are most often felt in the plantar aspect of the foot or the toes, or sometimes into the dorsal web space. And those symptoms can be made worse with walking or loading of the forefoot. Diagnosis can be made through taking a thorough clinical history. Patients will often tell you that they wear tight or high shoes, as I've just mentioned. They may partake in activities that lead to overloading of the forefoot. They might be a runner who tends to strike on their forefoot. Pain, they may tell you, can be relieved by rest or by releasing the compression, for example, removing their shoes and massaging the area. Clinical tests would be the good old Mulder's click, the compression. We can also do a diagnostic local anaesthetic, are also options of ultrasound or MRI, but often a good history and compression tests are enough. You can get false positives or false negatives with ultrasound. Just because the nerve's enlarged doesn't necessarily mean that there is actually a neuroma present. It has to be accompanied by your clinical history taking and your testing. Okay, so differential diagnosis for Morton's neuroma, lots of differential diagnosis, synovitis, bursitis, stress fracture, ischemia, sometimes tarsal tunnel syndrome can mimic the symptoms of Morton's neuroma as well. So lots of things to consider when we're making that diagnosis. So pathology, what exactly is going on when a Morton's neuroma is present? So the actual pathology includes swelling and inflammation of the digital plantar nerve in the intermetatarsal space, and there may be thickening of the adjacent tissues as well. You might see degenerative and or ischemic changes in both the nerve and the surrounding tissues, and there may be endo, peri or epineural fibrosis, which means adhesions in and around the nerve. And finally, there could also be fibrosis of the adipose tissue and the blood vessels, which may contain thrombi. So lots of different things going on in there. So currently, common treatments for Morton's neuroma are corticosteroid injection therapy and mobilizations and manipulations. These are kind of classed as the most effective treatments available at the moment as far as the research goes. We can also throw in like things like footwear modification and padding, which is designed to offload the area. Let me get to my right bit of paper here, sorry. What slide am I on? 7. With surgical removal, there is the invasive nature of that to consider, and the fact that there's a risk of regrowth or stump neuroma formation. We can use wedging to try and offload the area as well, shockwave therapy, lots of different options there, and of course laser, which is what we're going to talk about tonight. So as far as laser goes, there isn't a huge amount of research out there to say that laser is highly effective for Morton's neuroma, but I think that's just a lack of research being done, and not that it doesn't actually work, because anybody who's got the MLS laser and has used it on Morton's neuroma knows that it can be really effective, and I'm going to tell you why that is. So how can laser help? So if we think about the actual elements of the pathology, so as I've mentioned, there is swelling, there's inflammation, there's fibrosis and potential ischemia. And then we think about the key ways that the laser works. So as we probably already know, maybe not everyone does, but the laser helps to reduce pain, it helps to reduce inflammation, it helps to reduce swelling, and to power up our body's healing process. So therefore, in a Morton's neuroma, the laser can help to reduce the swelling and inflammation of the nerve and the tissues around it. And the vasodilatory effect of the laser will help to bring blood to those ischemic tissues. And by reducing the inflammation and swelling, we can reduce that kind of internal compression of the nerve by the surrounding structures. We also know that laser can increase the speed of nerve regeneration because it activates axon sprouting and works to accelerate myelination by stimulating Schwann cells, which produce the myelin sheath. And it also increases the cellular metabolism. Laser also modulates pain by having an effect on the nerve response in that it affects the action potential and reduces the speed of the pain impulses. So anybody who has a laser will know that there's no preset on the laser for a Morton's neuroma. So when we are treating that with our lasers, what we need to do is break down the components of the condition that we're trying to treat and choose accordingly. So I'll talk a little bit more about that in the actual case study, which is my next slide. Okay, so this patient, this picture will make sense, I promise. This patient was a 46-year-old female. She's in good general health, quite tall and slim. She works as a dog groomer, so she's on her feet a lot and she's very active. She does karate, training 3 to 4 times a week, fairly intensively. She also likes walking and cold water swimming. Her footwear tended to be walking boots or a trainer style footwear, so not overly overloading her forefoot or compressing it. She never wore heels. She noticed her issue particularly when she was barefoot at karate. So after a thorough history taken and clinical examination, we diagnosed her with a Morton's neuroma. So I actually messaged this patient yesterday just to catch up with her and get a recap of her condition and her treatment in her own words. So this is what she said to me. She said, I had pain in the pad of my foot below my 3rd and 4th toes. It would come on after a lot of walking, making it too sore to walk further. Sometimes when I'd had no pain walking, I'd get a sudden shock from that spot, as if I'd trodden on a piece of Lego barefoot. And I'm sorry, this explains the image. It seemed like too good an opportunity to pass up to be able to sneak a standing on Lego meme into a presentation. I often had, this is her words again, not mine. I often had no feeling in those toes either. I tried soaking my foot in hot and then cold water alternately, and heat or ice packs to try and invigorate the blood flow, which worked in the immediate short term. During the laser treatment near the end, it felt like the blood flow had been restored, and afterwards those shock moments had stopped. I got insoles to maintain the shape of my foot afterwards and had no more problems. So her description ties in really well with the common symptoms that I've discussed, and also the pathological description of a Morton's neuroma too. So because this patient is barefoot at karate, we couldn't really rely solely on orthotics, no pun intended. And we really needed to calm down that inflammation for her, aside from the other interventions that we were going to put in place. So the treatment that we gave her did include orthotics. We gave her a basic pair of SlimFlex EVA orthotics with a teardrop pad and a pour-on top cover. And then we gave her some laser treatment as well. So I have to thank Enya Ekbans for this protocol. This is her protocol, which she shared in the Laser Forum group on Facebook, and I know it's successfully used by lots of different people to treat Morton's neuroma now. It just works really well. So when you're treating Morton's neuroma, bearing in mind that you're in between two bones, you're in quite a tight area. So you need to think about your optical windows as well, and how best you can get the light into that space, maybe even using your fingers to open up that space between there a wee bit if you can. So the settings that we used were brachial neuralgia, which you can find in the neck box. We're stealing a setting from one area to use it in another, and that's completely fine. So brachial neuralgia has got 6 points. So we use 3 points on the dorsal aspect, covering the affected area, 3 points on the plantar aspect. We then use inflammation. So in the NDS protocol, we just drop the time for that down to 2 minutes, and we're doing 2 minutes dorsal, 2 minutes plantar. So that's a constant movement with the scanning, with the inflammation setting. So you're just continuously moving the laser around the area that you're treating rather than focusing on individual points. And finally, we did trigger points and dropped the settings down to the magic 10 Hertz, 23 seconds and 25%. And again, 3 points dorsal, 3 points plantar for that. We did a total of 2 treatments for this patient. That was all she needed. She was feeling so much better after that. The clinical reasoning for those settings are that brachial neuralgia targets nerve pain and irritation, which is what we're dealing with here. The inflammation further targets inflammation. And the 2 minute setting, as I've mentioned, allows for a more general treatment. And then the trigger point hits the acute elements of that pain. So I'm sorry, I should have gone on to this next slide. So the patient, she had no further issues until she went on holiday for 10 days. So she said that after her holiday, the pain began again. And on reflection, she realised that she hadn't been wearing her insoles at all while she was away, and she'd been doing a lot more walking and activity. So she contacted us for a top-up treatment, which she came in for last month. And when I spoke to her the other day, she said that that seemed to have done the trick in calming it down again. So for this patient, this was really good. It meant that it calmed down that pain. Even when she didn't have her insoles in at karate, she was able to go barefoot. She didn't feel like she was standing on Lego, which can only be a good thing. And it doesn't really bother her anymore. And she knows that if she does something or that causes a flare-up, she can come back to us for a top-up treatment, and that will get her to a good place again. That is me. I'll stop sharing now.
Brilliant. Thank you, Kirsten. Great. Thank you for taking us through that. That's brilliant. I will at this point as well now introduce Paul Siddy. Introduce Paul to those of you that don't know Paul. Say hello, Paul.
Hello.
Well done. Great.
And I'll go back on mute now.
Okay. And Patrick is with us. I'm pleased to say, good evening, Patrick. Patrick there.
He was there, but he's
yes, there. I can see him.
It's when you introduced him, Steve, he ran away.
I have that effect on many people. For those of you who don't know, so Paul, Patrick and Kirsten really are the A-team. They're our panel of experts. Kirsten obviously leading this evening with Morton's Neuroma, but the guys all here this evening to take your questions. So just wanted a quick hello to those guys, so you're all aware. Let me go to chat and see if we've got any questions that have come in. I think there was one I noticed. Oh, Nikki's just asked, sorry, what was the trigger setting again, please? You might have had that on the slide, which we didn't.
Yeah, that I forgot to change. I told you I was going to forget to
I wasn't
change
sure whether to jump in.
You didn't know I had that one, though. So the trigger settings were 10 Hertz for 23 seconds, 25% intensity. And I've seen a couple of questions about how frequently and how often. So we did 2 treatments, and we did those weekly, one week and then one the next week.
Brilliant. Okay, thank you. Yeah, you've covered all those questions. Thank you. Hope that answers your questions, guys that have asked those questions. Just jump in again if you've got need any more clarity on that. But that's great. That's really, really great. And as you mentioned, there's no actual setting for Morton's Neuroma, so it's really just a case of knowledge as we go along, and that's exactly why we do these webinars. It's exactly why we have the laser forum where we share this kind of information. So that's really, really important to stress. Okay, so listen, guys, everybody out there, the rest of the evening is yours. In as much as you ask the questions, you pose the questions. We've got 3 guys on standby that can ask any number of questions.
Steve, can I just make a point? Because I thought Kirsten, that was fantastic. Thank you very much indeed.
Thank you.
Very informative. I'm not a podiatrist. I deal with Morton Neuroma and stuff. I see a lot of foot stuff as well. I'm a physio. But my approach is always this, and I'm sure Kirsten is the same. But my point is this: we're talking about what the Morton's neuroma is, or whether it's truly a neuroma. Well, it doesn't really matter. What we're talking about is compressive forces is probably often the biggest problem you've got there. Whether that's from tight shoes crushing these metatarsals together, or whether it is another thing, which I think it's something that should always be looked at, because your patient got a lot better, and then she went back and things started getting bad again. And you ask, why was that happening? And I would always say to these people, I just do a little test, have a look at their feet, see how much they drop, see what is the strength of the medial arch. Because if you, let's say, for instance, if I stick a pen there between my fingers like that, and I crush all my fingers together, it's going to hurt like hell. Okay, now that is because what's happening is, if you just try to imagine my hand as the foot and the metatarsals there, if we've got weak intrinsic muscles, what will happen is when we weight bear, that is just going to drop down. It's a very similar problem that happens in plantar fasciitis as well. But we're dropping down here. But what that does is that naturally compresses these metatarsals together, which, remember back to my pencil in between the fingers, which can cause some pain. And you're absolutely right, Kirsten. She went on holiday. She hadn't been wearing orthotics. Why did the orthotics make such a difference? It's because there was no arch support. You've got weakness in there. And often I tell people with this Morton neuroma, yes, we do the mobilizations on, we will use the laser, but the other thing I give them is always some strengthening of the intrinsic muscles. And that comes down to as simple as just towel scrunching. Just spend every session of Coronation Street towel scrunching. So, you know, that's a lot in a week. And you will actually build up the strength. And if we can, then obviously the orthotics can help naturally, because not letting the drop happen. But keep enough strength coming into these intrinsics, you'll actually get to the stage where you probably don't even need your orthotics anymore. And obviously, you're going to stop the Morton's neuroma or the neuroma coming back. So just thought I'd make that point.
Yeah, thank you, Paul.